I met Billy a little while ago, and he has to be easily one of the most humble and kind individuals you will ever meet. And so when you do engage with him and talk with him, his presence is amazing, and you can tell he's a really good provider by that presence that he creates. So Dr. Rutherford is a psychologist, and he specializes in the post-traumatic stress disorder. He works at the Hershey, I say this wrong every time, Hershey, yeah, there you go, Herschel Woody Williams VA. We don't make it easy to say any VA facility name. In Huntington, West Virginia. He's had about 15 years of experience delivering evidence-based interventions with veterans with trauma related to kind of disorders and conditions both in and outside of service. He earned his PsyD from Marshall University and is the immediate past president of the West Virginia Psychological Association. And Dr. Rutherford is also doing some amazing work with virtual reality in the PTSD space. And I can personally say that some of the stories that have come from his engagement with veterans are definitely what we need to be highlighting of capabilities that we have with providers like himself. So with that, I'll hand it off.
All right, thank you, Evan, for that introduction. You did a fine job on that bio. It's great to be here. It's been a great conference so far. Are we having a good time? Yeah? Okay. I am cognizant of the fact that I'm between you and lunch right now. So I will try to keep this moving. I've been asked to talk about immersive technology and rural veterans because about 2.5 years ago, that's what piqued my interest in possibly looking at VR and immersive technology to fill in some gaps for some of the population that I serve in my medical center. We serve southwestern West Virginia, a large portion of eastern Kentucky, and southern Ohio. There's not a lot of large metro centers there, and some people live some, fairly, in some respects isolated lives in terms of, being able to access large crowds or ethnic and cultural diversity, public transportation. Some of these things that I'm going to talk about can be triggers that are associated with anxiety and PTSD responses. And when you're delivering evidence-based treatments for trauma, we have some really tried and true evidence-based protocols that do some wonderful work for people. A lot of them have some common elements to them. I'm talking about things like prolonged exposure, or PE, cognitive processing therapy, EMDR, written exposure therapy, and so on. We're really combining some techniques to try to improve engagement or non-avoidance with both internal experiences, meaning cognitions about traumatic experiences and their aftermath and ourselves, internal emotions, images in our head. And by avoiding those, people seem to get on a track where it might seem they're doing okay day to day in the short term. But we know that the people that are better at pushing away those things, pushing away those emotions, using distraction as avoidance, not talking about things, avoiding getting around crowds, avoiding getting in certain types of situations or around sounds, they tend to have the symptoms longer and fail to have that natural recovery. So that's a big hallmark of all of our evidence-based interventions, is using exposure. There's two different types that we usually split into. We've got imaginal exposure, and I'll talk to veterans about that's kind of for your inside avoidance, even though that's kind of a gross generalization because it overlaps. And that's internal memories, emotions, sensations, or attributions associated with traumatic experience. And then we have in vivo exposure, which I'm going to focus on. We also have really good tools that can help enhance imaginal exposure. Dr. Skip Rizzo's Brave Mind system comes to mind. We have in vivo exposure is usually what I talk to veterans. This is your outside avoidance. External reminders or triggers. If you think about Pavlov and his dogs, when you can associate something that used to have a neutral meaning or no meaning, but it happened at the time of a traumatic event, it can automatically call up a variety of sensations and thoughts. So that's kind of things we're trying to find out, how can we kind of undo those associations over time. If you look at this graph, it's really just showing what we're trying to get over time. The different lines are different trials of being around, a situation, maybe an in vivo exposure, or talking through a memory in imaginal exposure. And over time, spending more time with that, you kind of have this wave, and you're trying to get to the other side of that wave with your distress. So on the vertical axis, that's subjective units of distress. 0, I'm as comfortable as I'll ever be. 100 and is the most distressed I've ever been. And just hypothetically, this is what we're trying to achieve over time. How can immersive technology help with that type of exposure? Well, there are all kinds of advantages, more than I could list here. First of all, it increases your degree of control over the stimuli. Typically, if I'm setting up an exposure hierarchy with a veteran and they're like, well, I'm having trouble with large crowds, so we might say, okay, well, where can we find some large crowds? Let's maybe go to your local grocery store, and we'll try to predict when there's going to be different crowd levels there. Because we don't want to start you at the deep end of the pool. We want to kind of do the technique where you get in a cold pool in the shallow end and just go up to your knees and get accustomed to it over time. But I don't really know how many people, they don't really know how many people are going to be there or what's going to happen that day. They might be having a special event, and then it really, you have a setback. Well, if you can practice this in a virtual or immersive environment, you can predict exactly, to some degree, what the intensity level is expected to be like. So it's a kind of a better first step into that water. They can practice as many times as they want to at a very low time investment. If I'm talking about a rural veteran that might have to drive, and this does happen, drive an hour to a department store to practice in vivo exposure, that's really hard to adhere to that, to get enough rounds of that exposure to really start to help in a short amount of time. So by doing this, you can do some supplemental practice in a VR environment. It doesn't have to adhere to the boundaries of one's environment. I'm talking about a rural population. Even at that store, you may not ever encounter a lot of cultural or ethnic diversity. But when they go on vacation with their family and they want to go to a larger metro center, they're already getting pretty amped up about that. That came into my mind years ago. I had a veteran that had finished prolonged exposure, and years later, I got a panicked call in my office. He had went to a larger city and they were at the mall, and he was in a fitting room having a panic attack because he saw some people in traditional Middle Eastern dress. So that's hard to access on a regular basis for him where he lives, but in VR we can access any type of person potentially. It may increase overall perceptions of safety to kind of get started. Getting started is the hardest part. Getting through the door, that's your hardest exposure. And with in vivo exposure, you could also have more privacy while you're doing some of these things. If you're doing real life practice and the only place around you is the Dollar General where everybody goes and they see you in there and you're in there several times a week, you're not buying very much, it's a rare thing, but I have had veterans be approached by people there or the manager and kind of questioned about what you're doing here. So then they have to maybe divulge some privacy they didn't want to. So if you do more practice this way, we were talking about the dangers of privacy earlier. Sometimes there's some advantages for your privacy with something like this. There's a link to a map down here from Rural Health Info. I just put that on there. It's an interactive map. You can see the population of veterans in the U.S. as of about 2020 and how it's distributed. And if you look at the metro versus non-metro areas, the amount of land that's taken up by non-metro area veteran population is astounding. And that's about 30% of the veteran caseload. So we're really covering a wide area with that. I didn't want to, I only had 15 minutes. I didn't want to go over all of the research basis for using immersive exposure. So I'm going to summarize some large meta-analyses that were done a few years ago. And the highlight is, the major points are, immersive exposure techniques are consistently, majority of the time, found to be as effective as these other frontline therapies that I've talked about that use exposure in general without VR. So like prolonged exposure, like written exposure therapy, those types of things. But it hasn't been found to be superior to that, but I don't really think that's the question. I think it's good news that it's as effective because it could fill in some of these gaps that we're talking about: greater sense of safety, privacy, rural issue concerns, those types of things. So this is a quote from one of the big meta-analyses. In light of these findings, it seems appropriate to infer that these well-controlled treatments, which I've mentioned for PTSD, should be the first choice whenever possible. So not replacing those, with VRET or virtual reality exposure therapy providing an alternative in scenarios in which the opportunity for in vivo treatment, for instance, is lacking. And my argument is one of those, and there are many, would be kind of a rural versus urban population. So I approached the VA Immersive team about this idea, and over the years now, I've got to be a subject matter expert and kind of champion on a couple of pilots. These vendors are out in the exhibit hall. There's XR Health, used to be called Amelia Virtual Care, and they've updated. They have both computer-generated environments and some unscripted 360-degree video environments of large crowds and things. They have fear of flying, heights, tight spaces, elevators, medical situations. Like, as an exposure therapist, it's like going into a candy store, with computer generated, you have some customization there. You can change some of the parameters in real time and you can see what they're seeing. Another approach was, we're developing some videos. I got to be on a team of subject matter experts with Penumbra on the REAL system. And those are 360 video, but they're scripted. There was a director and a cast of actors, and priority was given to veteran actors. And we came up with some scenarios that we could kind of plan out how the intensity was going to increase, over the time that you're spending in there. Last year we did a diner and a grocery store. I'm going to show you some examples of those environments, and it depends on which aisle you're in, what the expected intensity level is going to be, and you kind of move through the store. And the other is a diner, and you can pick to set in locations that will probably be experienced by the veteran as low, medium, and high intensity. And then we have, here it is, several other new environments that are just out. There's an outdoor rock concert. There's a witnessed mild medical emergency that happens there. There's a cultural fair that goes on that you walk through, a vintage car show, and an outdoor fireworks display. So it combines the realism of video with some customization because you can kind of know what to expect when you're setting this up. So this is kind of an example of a low intensity environment from the grocery store. So these aren't the kind of things that people, if you don't have PTSD, are going to put on and be like, wow, this is really fun. It might seem kind of boring, but it's a good toe in the water, and if you have hypervigilance going on, it could be, triggering a lot of things. Here's a medium intensity from the diner. So here you're kind of in the middle of the wall, so your back's still to the wall, but you can't see every exit. And there's going to be a few more people in there. There's a baby that cries. There's a little bit more diversity.
You all set to order?
And this is a high intensity from the diner.
Seriously, do not have time for this.
23.
People are getting a little upset around you. They're not being waited
Gonna get
on. Even the presence of that raw meat, we purposefully put in there because that's on a lot of exposure hierarchies depending on the type of trauma. And then we wanted to put in some reinforcement values as the subject matter experts came together and thought of, once you reduce your SUD level by a certain amount and watch enough time in these videos, you have a challenge coin ceremony.
On behalf of all of us here, we would like to congratulate you for completing the program.
This is a great accomplishment, and you should feel very proud.
So that was both in the diner and the grocery store. Now this is, I think it goes into a little bit of the outdoor fireworks display. Now tomorrow Dr. Rizzo is going to go through some of this as well, and he's got some things after post-production. This is when it wasn't quite ready for prime time, but I have this video clip from Penumbra. So it's at dusk. You have a very brilliant fireworks display that keeps on going in intensity, and the fireworks are actually CGI. So it's combining CG with the actual 360 video. Dr. Rizzo was in the crowd in this shot of the fireworks display. He's kind of, if you turn around, he's kind of behind you. And with 4th of July coming up, if you have veterans and you work in mental health, you know this is an annual talk that you have about preparing for fireworks. So you could potentially do this any time of year to kind of keep your skills up. And then this is kind of an overview video. We won't watch all of this, but it's kind of showing what all went into the new environments and working with the actors, some of them veterans. It was really a big production, and really a lot of resources went into it to make things go off in kind of a scripted way that still seems realistic. There's a director there setting up the medical emergency and some actors responding to it. This is during the rock concert. So if you have first responders or medics or corpsmen, maybe that could be something that's relevant you can kind of replicate without really endangering anyone. The antique car show, there's going to be cars backfiring, noises, such. Okay, so I know we're about out of time. So how am I using this? Again, it's a tool. I'm not replacing standard care, but expanding that as an introduction to in vivo exposure techniques that may seem safer, or maybe just pique curiosity. I mean, we all love seeing these things and trying on the headsets. Additional tool to deliver an already evidence-based protocol, or as a booster course of exposure. Someone experienced something you didn't work on in a hierarchy before. It's another creative way to try to get to that. So future steps, we're going to continue to pilot these and hopefully do some effectiveness trials, because I think that's the next question. Are these specific ones that were created for the VA going to show real clinical effectiveness and utility? So that's all I have, and we're out of time. So I thank you for your attention.